Thank you so much for joining us. I'd like to welcome everyone to the STS 2025 webinar series. Today's webinar is titled VAD, Surgery Unplugged, Insights from Global Experts. This is a collaboration between the Society of Thoracic Surgeons, the Society for Heart Failure and Transplantation, and the Indian Association of Cardiovascular-Thoracic Surgeons. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I'm pleased to introduce our moderators for this webinar, Drs. Julius Poonen and Dr. John Morala. Thank you so much. I'm going to invite everybody on the video at this time.
Hey. Hello, everyone. Welcome to our STS South Asia webinar series. And I'm really humbled and privileged to see how this collaboration is growing very strong. And we had 3 successful webinars with great participation, and this is the 4th one in the installment. And this being like a topic which really goes untouched by residents and everyone. So, which is a really important one, which is the future of heart failure treatment in cardiac surgery, which is on LVAD. So before I take up much of time, I'd just like to share my screen to Dr. Madhuri to just a few words before starting on. Okay, I'd like to call upon Dr. Chris to give us a few words about the collaboration and give us a thing about we have a great section, the IACTS count plan. Thank you.
Well, thanks, Dinesh. Well, good morning, good afternoon, and good evening to all of you joining from around the world. I'm Chris Malaysia. I'm a cardiac surgeon at Northwestern. I also chair the STS workforce on international education. And on behalf of the Society of Thoracic Surgeons, it is my pleasure to welcome you today to today's joint webinar with the Indian Association of Cardiovascular and Thoracic Surgeons and the Society for Heart Failure Therapy, focused on ventricular assist devices. The STS IACTS collaboration continues to strengthen our shared commitment to advancing cardiac surgical education globally. Today's session highlights one of the most rapidly evolving areas in our field, mechanical circulatory support. We're fortunate to have an outstanding panel of experts who will guide us through the latest development in VAD implantation strategies, patient selection, perioperative management, and long-term care. Their experience offers valuable perspectives for surgeons and all members of the heart failure team. We encourage you to engage actively, submit your questions to the chat, and take advantage of this opportunity to learn from global leaders in the field. Again, thank you for being here, and I hope you benefit from our program.
Thank you, Chris. That was a really great one. I'd like to call Dr. Manoj Dureraj sir to start up this section here. Thank you.
Greetings, everyone from different parts of the globe. Good morning to everyone in the US, and good evening to all of us in India. It's my pleasure to introduce the Society for Heart Failure and Transplantation. This society was established in 2013 as a non-profit organization to improve awareness, research, education, and patient care in the fields of heart failure and transplantation. The objective of the society primarily is to provide a forum for all interested in heart failure and heart transplantation and to educate healthcare providers, like the webinar which we are having now, on the current trends in heart failure management. It also improves the organ donation program in the country by having various camps and sessions for the common people, and that is what is important when we are looking at a country like India, where there is a problem with organ donation as you go to different regions. In the 12 years of our existence, we have reached out to different parts of our country. We have become a truly national organization, and I'm so happy and thank you, Chris and Madhuri and Dinesh and the team at the STS for collaborating with us for this global webinar. I like to invite Dr. Jabir Abdullah Kuti, our president, to introduce the moderators for today, Dr. John Murala from the US and Dr. Julius Poonen from Bangalore, Narayana Hridaya. And over to you, Dr. Jabir, our president.
Thank you. Thank you, Manoj. It's indeed a great pleasure to be here as a part of this webinar, which is done in collaboration of STS with the Indian societies involved in the care of heart failure patients, the Society for Heart Failure and Transplantation and IACTS. It's an extremely important session to know about the VAD surgery, which is an imperative component of advanced heart failure therapy. And we are extremely blessed to have or to be joined by the two eminent people in this field as our moderators. One is Dr. John Murala. Dr. John Murala is Associate Professor and Surgical Director of ex vivo heart lung perfusion in the Department of Cardiovascular and Thoracic Surgery at Southwestern Medical Center at Dallas. And he has all his basic education from India, his graduation, post-graduation, as well as his training in cardiovascular surgery. And his research interest in EVLP, thoracic organ preservation, large animal model research, adult congenital disease leading to heart failure and heart care in low and middle income countries. That's what we are extremely would like to hear, how we can improve the heart failure care in advanced heart failure in low and middle income countries, where for many of us, VAD is a dream, to put a VAD or to keep a patient on VAD. And the second moderator is Dr. Julius Punnen, who is the immediate past president of our society. He is the director of advanced cardiopulmonary therapeutics at the Narayana Institute of Cardiac Sciences, Bangalore, and with great experience, or I must say, one of the leading heart and lung transplantation surgeon in India, with a great experience in the cardiac support devices or mechanical cardiac support, especially VAD and the ECMO, and also his exemplary work in the field of pulmonary endarterectomy. Welcome Dr. John Murala and Dr. Julius Punnen to this meeting, and I may hand over the session to you for the rest of the academic exercise for next 45 minutes. Thank you. Dr. Julius and Dr. Murala.
Dr. Murali, you're on mute.
My apologies. Okay. Dr. Punnen, do you want to introduce Dr. Ranjit John?
Sure, thanks. Good morning and good evening to all attending here. It is my pleasure to introduce my good friend, Dr. Ranjit John. Dr. John received his medical degree in the famous Christian Medical College at Vellore, and then he went on to do general surgery training at New York Medical College, and also did a research fellowship in cardiothoracic surgery at the Columbia University at New York in 2002. He has been at the University of Minnesota since 2004 and has been a professor since 2017. He previously served as a surgical director at the university's mechanical support program for 15 years and has been a clinical investigator for several trials in the field of mechanical circulatory support. He also serves as the surgical director for the adult ECMO program and the surgical director of the University of Minnesota's heart transplant program. He was promoted to be the chief of the division of cardiothoracic surgery in 2002. He has authored or co-authored over 200 peer-reviewed publications in the field of heart failure and has numerous national and international presentations in this field. He has been instrumental in training the first lot of VAD surgeons by conducting live workshops in India many years ago. And he has been attending many of our heart failure conferences and contributing a great deal to these meetings. Thank you, Dr. John.
Thank you, Dr. Sorry.
Yeah, sorry. Go ahead, Ranjit.
No, go ahead. I'll follow you.
Okay, well, I mean, it's my pleasure to introduce Matt Peltz. Dr. Peltz is, I work at, he's my colleague, and he's my he's our director of heart transplant. So he is a professor at the University of Texas Southwestern Medical Center. He's also the surgical director of cardiac transplantation and mechanical circulatory support. He also has the associate appointment in the Department of Biomedical Engineering and adjunct faculty appointment in the Department of Bioengineering Texas at Arlington. His clinical focus is on surgical management of patients with end-stage cardiopulmonary disease, including cardiac transplantation, ventricular assist devices, lung transplantation, and temporary circulatory support. Dr. Peltz's research interests are in cardiac and pulmonary metabolism, machine perfusion, preservation, and myocardial imaging, and mechanical circulatory support. He is an expert in mechanics of machine perfusion, preservation, and biology of thoracic organ preservation for transplantation. He's a co-investigator in the SWIFT HeartMate 3 non-sternotomy approach LVAD implantation trial and in a multi-institutional study investigating VAD-induced neutrophil dysfunction that may predispose patients to infectious complications. Dr. Peltz performs over 90% of his LVAD implants by sternal-sparing approaches. And I've been here for almost 9 years, and whatever I've learned about VAD is from him. He's a great teacher, and I work with him in many of his projects in his lab and also help him with many of his VADs. So it's great to introduce my colleague and Dr. Peltz, a great mentor.
Thank you for the kind introduction, John.
So I guess we'll start with the webinars right now. The purpose that we are here for, and it will be Dr. Poonen first, and followed by Dr. Peltz, and they will switch over automatically once Dr. Poonen finishes. We will take all the questions in the end, and please put in your questions in the chat box below. We'll be monitoring the chat box, and we will take the questions from there. Okay, Dr. Poonen, over to you.
John, unfortunately, it's going to be me instead of Dr.
Sorry.
Poonen.
Well, what am I saying? I mean, it's Ranjit. Ranjit, my apologies. Yeah, please go ahead.
Not a problem. Yeah. And you can see my slides, right?
Yes, we can.
Okay.
Go ahead and click slideshow. You're all set.
Be able to move the slides. There you go. Okay. Perfect. Thanks. Good evening, everyone. And thanks, Julius, for that kind introduction. My task over the next 15 minutes is to talk about evolving strategies in durable LVAD implantation, some lessons from long-term experience and how the field has evolved over the last 10 to 15 years. If you look at what the current media or the current face of LVADs is over the last 5 years, you hear two constant themes. One is LVAD use as a bridge to transplantation, which was the workhorse of our field for almost 2 decades, is down, as shown from, both these papers that show a significant decrease in VAD usage as a bridge to transplantation. The second theme that you consistently hear is LVAD as a bridge to transplantation, in addition to a reduction in its use, is also associated with a reduction in survival, relatively speaking, as again shown from a couple of these studies over the last 3-4 years, including one from our group that was published in 2022 in JTCVS. However, let's look at the Intermax report, which is a database in North America for real-world outcomes of patients receiving permanent mechanical circulatory support. And note, these are only FDA-approved devices. What is staggering on the Intermax database, it involves almost 200 centers, and over the last 10 years includes almost 30,000 patients, including about an average about 2,500 to 2,800 patients a year. So again, the STS Intermax, shows, as I mentioned, almost 30,000 patients, and we are going to focus on recent outcomes, including the traditional non-maglev, which is currently replaced by all maglev implantable devices. Now, this bar graph over the last 10 years shows in light blue how, since the introduction of the contemporary maglev, which is the HeartMate 3 in about 2018, again, that's when it was FDA approved, over the last few years, 100% of devices in North America is by maglev. Again, that's the HeartMate 3 device. Heart transplant also continues to grow, but the gap between need and availability also continues to increase, as shown from the slide showing both heart transplants, VADs, and the overall need. Now, when you look at the HeartMate 3 implants that are being stratified by patient profile, what is staggering to note that the Intermax 2 to 3 profiles, which is amongst the highest acuity patients, 1 to 7, 7 being ambulatory at home, and number 1 are critical cardiogenic shock and patients at imminent risk of death within hours to days, shows that Intermax profiles 2 to 3 comprise 75% of all HeartMate 3 LVAD implants over the past 5 years. For almost a decade, the VAD field, including cardiologists and surgeons, have been saying there is excellent 1-year and 2-year survival, but what about 5-year outcomes in these patients? So again, Intermax is able to tell us this. And what we see is that real-world 5-year survival for HeartMate 3 LVAD patients remains excellent, consistent with what was seen in the clinical trial, which is Momentum. And here we see a 60% 5-year survival for HeartMate 3 patients, clearly a bar or two above what was previously available to us. Freedom from stroke. HeartMate 3 patients clearly experience significantly lower stroke rates in previous LVADs, with almost an 87% freedom from stroke at 5 years, which corresponds to a stroke adverse events of 9% at 5 years. Freedom from device malfunction, again, exceedingly low, with an adverse event rate for pump thrombosis in Momentum was 2.1% at 5 years. Freedom from GI bleeding over the eras. While clearly there is a reduction in GI bleeding, we do believe that continued improvements in the reduction of bleeding should become more apparent in future reports based on reduction of bleeding demonstrated in the recently ARES HeartMate 3 trial that looked at the use of no aspirin versus no Coumadin, etc. Infection continues to be probably the biggest Achilles heel of our field. There have been minor improvements, but clearly MCS-related infection for LVAD patients has not improved over prior devices or eras, and really is a primary target for improvement over the next decade. Looking at HeartMate 3 LVAD outcomes stratified by age, again, this is from our STS Intermax data. What we see here, that in younger patients, they exhibit a high survival in HeartMate 3 LVAD patients. Again, this is referring to patients less than 50 years old, supports LVAD implantation as a concept prior to heart transplantation in these patients, with the goal of net prolongation of life and potential for myocardial recovery, which, although low, still exists. And again, we see in this Kaplan-Meier curve a 73% survival at 5 years in patients under the age of 50. We also briefly talked about GI bleed, and we see that the low GI bleeding risk among younger HeartMate 3 patients again is an advantage for VAD implantation in younger patients. In addition to a significant reduction in stroke for HeartMate 3 patients overall compared to prior pumps, we see that younger patients even enjoy a lower stroke rate than older patients, consistent with what's out there for elderly patients versus younger patients in the general population. Unfortunately, time to first infection in HeartMate 3 LVAD patients does not pose an advantage in any way for the younger patients, and which comes back to our current transplant allocation system, which does recognize the morbidity of LVAD infections, allowing for some reprioritization of transplant listing. However, I do think we got to make a better concerted effort that transplant eligible VAD patients should be assured that if infection does occur, there is a true opportunity to move forward with heart transplantation, as once these patients get a first driveline or any sort of infection, recurrence is only a fact and not a probability. Device malfunction continues to be exceedingly low in all ages. As mentioned earlier, the risk of pump thrombosis is a staggeringly low 2.1% at 5 years in Momentum 3. So again, I have this cartoon here that whether for young patients under the age of 50 prior to a heart transplant, can one have the concept of LVAD, get them 5, 6, 7 years, and then the heart transplantation with a goal of overall prolongation of life. Having kind of set the stage for what's been there over the last decade, which is mostly and maybe only been HeartMate 3, which is the currently approved maglev device in the field, let's look at what is new and upcoming in the field. It's a sobering fact that the development of durable mechanical circulatory support devices has been a long and arduous process spanning over 60 years. I have been experienced some of these previous devices right here in the middle of the screen. If some of you can identify the HeartMate 2, it's hard to believe that the HeartMate 2 is abandoned almost 6-7 years ago. But for almost a decade, from probably 2005 to 2015, was really the workhorse of the field. So in some ways, we have made a lot of progress, but in some ways, the progress has been exceedingly low. And 1966 refers to the first time Michael DeBakey used a durable mechanical circulatory support, obviously in a patient with limited survival. So clearly, in summary, the total maglev centrifugal flow LVAD technology has achieved the best outcomes ever reported for durable mechanical circulatory support therapy, with a 1-year survival of close to 90% and a 5-year survival of 64%, with significant and sustained improvements in functional capacity across all age groups. And again, this slide from the STS shows, again, a 5-year survival, which is outstanding. And this slide shows that looking at even up to 7 years, the durability of LVAD support has been fantastic. And we saw about the improved quality of life and functional capacity with durable LVAD support. It has become clearly an ambulatory pump, patients going back to work and contributing to society in many ways. But clearly, looking at all these 4 major complications, infection, as I said earlier, remains the Achilles heel of the field, with many issues such as device malfunction have almost ceased to exist. We also need to be reminded, or we don't need to be reminded on a daily basis, that systolic heart failure is hugely prevalent in our disease, what we see, and that number is only going to grow with poor long-term survival with current medical management strategies. We also need to be reminded that not all advanced heart failure can be treated with heart transplantation, as we see the 3-year outcomes for patients who are listed, continues to grow, and pre-transplant mortality among patients who are listed is still a problem. In this slide, we see that the 3-year listings, at least in the United States, continues to increase. While the number of heart transplants has also grown, there clearly still is a waiting list issue. In the United States, the transplant allocation that was changed in 2018 has received much attention. One of the big take-home messages has been there's been a massive rise in the use of temporary mechanical support, ECMO, short-term support like impeller and balloon pumps. Coexistent with this, something that I already mentioned, there's been a significant decrease in the use of durable LVADs, and durable LVAD bridge to transplantation, which was the bastion of the field, is no longer mainstream. And again, to finish off with some more of the STS Intermax, we see that the annual sum of durable LVAD and heart transplant continues to increase, which is a good thing for the field. And we've talked about how device strategy as a bridge to transplantation, shown in light blue at the corner of my screen, has really diminished, and that the patient profile has significantly altered, in that over half, as shown in this bar graph, are the patients with critical cardiogenic shock. The sickest of the sick patients are receiving LVADs. We also see in this graph that even in patients receiving LVADs, that the pre-implant use of temporary mechanical support, whether it's balloon pump, ECMO, or impeller, continues to increase. So where are we in the field? It's a sobering realization that we are treating mostly acute cardiogenic shock. We clearly are restricting LVAD therapy, at least in the current format, to the pool of patients that fail an attempt at transplant. This is significantly different from algorithms from a decade ago. We also see that, other devices such as pacemakers, bibeat therapy are often used in less sick patients, and we reserve LVAD therapy for the sickest of the sick. The field has achieved tremendous clinical success. Yes, durable mechanical circulatory support remains a niche therapy, and clearly the HeartMate 3 has represented stability and not disruption of what we do. While the field has achieved strong clinical progress, clinical wins have not translated into the mainstream adoption as many of us would have liked. Alignment is clearly needed with funding, regulatory, and design risk ventures. We know the technology works. We know we made substantial progress in reducing bleeding and stroke events, what we call as hemocompatibility. And we really have solved a reliability problem by eliminating pump thrombosis, which was really the Achilles heel of the HeartMate 2 era. And in many ways, it has been a disruptive technology. If you go back and look at the survivals that have improved from 24% with the HeartMate XVE, or what we sometimes call as the HeartMate 1, to the 87% with the current maglev technology. This is a quote from Robert Jarvik. If the artificial heart is ever to achieve its objective, it must be more than a pump. It must be more than functional, reliable, and dependable. It must be forgettable. The next leap in durable MCS will come from engineering innovation, not just small incremental improvements. And the question is, what design advances could make MCS mainstream? The VAD is the closest or the lead in the field in terms of, have started a pivotal trial in the United States, and there are several other devices out in the horizon, including totally implantable systems. which I think will be the next generation of devices. The totally implantable systems that have been on in our workforce have been the Lionheart, the Jarvik, the AbioCore total artificial heart. This device, implanted in Europe shows completely implantable with this patient completely, bathing or swimming in a pool. What about miniaturization and partial support? There may be a move from full circulatory support to ventricular assist augmentation, smaller pumps, possibly transapical or transseptal insertion without a sternotomy is being considered. But I think the huge application that the field is looking forward is what is the potential for earlier stage heart failure use and broader patient population. Shrinking the pump can also expand the patient pools. The clinical success of HeartMate 3 has clearly reduced urgency for radical redesign. We've gotten into a phase of complacency where we are happy with the current results. Industry risk aversion and regulatory inertia has slowed the use of novel designs. Only a few true next-generation durable devices in human testing are in vogue. And really, what is the future for the next generation? The ideal MCS pump, fully implantable, silent, intelligent, modular, minimally invasive. Achieving it requires convergence from the biomedical industry, materials, energy data, and human-centered device. The future of a pump of the MCS is not just a pump alone, but an ecosystem with continuous monitoring and probably smart pumps with auto-regulation that can fit a patient's needs. I thank you all for your kind attention.
I think Dr. Pells can start up with the next section.
All right. Well, thank you for the invitation to present at this outstanding meeting. And it's going to be difficult to follow Dr. John with this excellent data-driven presentation. Can you see my slides?
Yes.
Yes.
Go ahead and yep, you may have to do the display settings switch. Yep.
There we go.
Perfect.
My presentation is going to be a little less data-driven. It's really related to sternal-sparing implantation, and I'll also finish up with some insight into pump exchanges when it comes to LVAD-related complications. Now, the question is sternotomy. Why sternotomy versus sternal-sparing implants? The data favoring one versus the other is I would say controversial. I think there are arguments for sternal-sparing approaches. One of the arguments is a more rapid recovery. Is there a reduced length of stay? Possibly there might be a reduced right ventricular failure, reduced infections, reduced blood product use, also reduced rate of reoperations versus sternotomy approaches, which in some ways is the standard, and it seems technically less challenging. It tends to be faster, although that's certainly dependent on the care team, surgical teams where you have experts for sternal-sparing implants on both the aortic approach and the apical approach. Those cases can move pretty quickly. Bypass time is almost uniformly longer for a sternal-sparing approach, and the ability to perform concomitant procedures is certainly much more feasible with sternotomy, though not excluded by a sternal-sparing approach. Mainly when we talk sternal-sparing approaches, I really want to highlight that for purposes of this discussion, this is either the bilateral thoracotomy approach via right anterior thoracotomy and a left anterior lateral thoracotomy, or a upper hemisternotomy plus the anterior lateral thoracotomy. These two differ really by their approach to aortic exposure. The left ventricular apex exposure is pretty much the same. There are other non-sternotomy techniques that are really applicable in exceptional situations like axillary arterial access or descending thoracic access if the ascending aorta is hostile or inaccessible for one reason due to calcifications or just a hostile surgical field. When we look at outcomes, I think the largest series, the largest report by Girardi et al. is a meta-analysis from 2021 that compared over 1,000 patients of about nearly 400 of which received a sternal-sparing implant and almost 700 sternotomy implants. And these authors were able to demonstrate that in a somewhat heterogeneous group of implants, where the majority was hardware devices, there was a reduced perioperative mortality, right ventricular failure, reduced transfusion, reduced length of stay, and a reduced need of reoperations using the sternal-sparing approach. Most of these accesses are outflow graft access was to the ascending aorta, and as far as aortic exposure, the majority of patients received a mini sternotomy. There were a small number of off-pump implantation in both. A number of concomitant procedures was higher in the sternotomy group, as might be expected. But interestingly, the INTERMEX 1 and 2 profiles were actually higher in the non-sternotomy approach patients. So in this manuscript, there seem to be some advantages to a sternal-sparing approach. Now, if you contrast this to the HeartMate-3 SWIFT trial, which I was fortunate to be a participant in, the data is less conclusive, and it doesn't really demonstrate any significant differences between the two groups. Just as a reminder, the SWIFT trial compared 100 patients with that underwent a sternal-sparing approach compared to these to 266 momentum cap continuing access protocol patients. And there are really no different, the groups overall generally they were propensity matched. There were, at least by the variables considered, relatively well matched. And overall, there were no differences in 6-month event-free survival, which is the standard VAD trial outcome definition of death, CVA or device exchange. At least numerically, the sternal-sparing implant length of stay was longer in this trial, and there was an increased right ventricular assist device use, though paradoxically, the absolute incidence of right ventricular failure was lower, although at a non-significant level. And interestingly, also, the ICU length of stay was less. The question comes up, why this discrepancy? And I think we have to look back at the enrollment criteria and the patients that were being considered in the two trials. I think the meta-analyses is really involved centers that are standard users of non-sternotomy approaches, whereas expertise and entry into the SWIFT trial required only 2 successful non-sternotomy implants. So likely there was a difference in the experience level between the operators. Both trials had made a majority hemisternotomy patients for aortic exposure. And one does have to acknowledge, though, that the HeartMate-3 is not ideally suited for a non-sternotomy implant. I think people that do this will, I think one of the biggest struggles is actually placing the pump after you've secured the sewing ring. Another factor could be an era effect. The SWIFT basically covered a lot of the COVID-19 pandemic and also was affected by the heart allocation system change. As Dr. John already mentioned earlier, the patient population in these trials was undoubtedly different. I think the DT patient in Momentum is a very different patient than the DT patient in the current era. The DT patient in the current era is not a transplant candidate because most transplant patients nowadays are moving immediately to transplant, and the number of true bridge patients is very low. And there are certainly factors that are not covered by the propensity matchings that impact outcomes in this population. And, and SWIFT does have an interesting finding, even though there's no statistically significant difference between bilateral thoracotomy and partial sternotomy techniques. Numerically, there does seem to be, there did seem to be an 8% difference in absolute survival between the two techniques. Just a quick thing about exposure. I think it's important to actually preoperative planning as far as always important in our field, but it's especially so when you're undertaking sternal-sparing approaches. I usually use mostly CT guided localization of which interspace I use for both the aortic and the left ventricular apical exposure. You can use echo guidance or ultrasound, but I mostly rely on the CT imaging. Incisions for the bilateral thoracotomy are shown here. This is probably second interspace, and this is, I'm guessing, more in fifth or sixth interspace. I use Alexa soft tissue retractors for both the aortic exposure incision as well as the apical incision. Small Alexis for the right thoracotomy, medial for the left thoracotomy, because the HeartMate 3 doesn't actually fit through the mini Alexis. Pericardiotomy and traction suture placement is actually quite important to move particularly the aorta to the surgical field. So the alternate hemisternotomy approach, this is a patient that's undergone a hemisternotomy implant. You see the sternotomy exposure incision, you see the thoracotomy incision. Whether you do a T or a J, that's not that important. Most of the time you get away with a second interspace incision. In the apical exposure is the same for both procedures. Just one interesting thing about this particular patient, he's actually got, you see a cannula here and you see a cannula here. He's actually on partial axillary ECMO support just for a transition, since he was on this preoperatively, and we used this as a transition to wean him off in the postoperative period. Localization, I've already mentioned some of this. I think apical exposure is allows for very precise device placement. Even though it doesn't seem intuitive, the position is you rarely have issues with the cannula being malpositioned. Like I said, I use the CT scan preoperatively, and that guides my incisions. You can use ultrasound, particularly when you start doing this, but the PMI by palpation is probably the most effective measure, and to localize the apex, and certainly in thin patients, that's what I use. Here's a couple CT scans taking just to illustrate these points. I think here on the left-hand side for the aortic exposure, I think the distance does matter. At some point, the aorta can be too far away to safely approaches. In that case, I almost always go to a hemisternotomy approach. You also want to see whether or not the aorta is not too leftward positioned. Traction sutures can bring it closer to the surgical field, but there is a point where you have to consider the hemisternotomy instead of using the right anterior thoracotomy access. I mean, since most of these patients are dilated cardiomyopathies, the apex is almost always very close to the chest wall, as illustrated on the right-hand side. This is so this image illustrates is really more about driveline placement. What I do is I tunnel, like most people, I tunnel pre-anticoagulation, pre-heparinization. We tend to favor, and we do this for our sternotomy implants as well, we make a subxiphoid incision for sternal-sparing that we don't have to do for sternotomy, and incise the anterior sheath and try to tunnel a driveline in most cases within the rectus sheath, and then to exit supraumbilically, and then if a subcutaneous final passage to either the right or left upper quadrant, whichever the patient prefers. You can also see the Alexis retractor for the aortic exposure, and here's the left apical exposure. I prefer the valure to be completely within the abdominal wall. Sometimes that's not feasible, and I'll live with an intrapericardial component. Whether or not you tunnel interpericardial or anterior to the pericardium in the preperineally for the initial passage, I don't think it matters a whole lot. I prefer it intrapericardially, just because it offers an additional anatomic barrier, but that's a theoretic concept. Cannulation, I think for partial sternotomy, you can just use your standard arterial cannula. I think exposure to the ascending aorta is very, very good. Like I said, most of the time you don't need to go beyond the second interspace. For the bilateral thoracotomy approach, I think imaging does guide whether or not I move straight to peripheral cannulation. If the aorta is very leftward, that's what I do. Otherwise, I kind of take a look and see whether or not I have enough aortic exposure. I've moved more and more towards central aortic cannulation. I just don't want to deal with the groin incision. I'm not super adept with percutaneous closures of my peripheral access. So if I do peripheral access, I do a standard groin incision. The cannulas, I do one thing about the aortic cannulation. I do use a percutaneous cannula because they are much more flexible, and it's usually a size larger than what I would use for the peripheral cannulation. But a 17 arterial cannula works for almost all patients, even rather large patients. Venous cannulation is in both cases generally with a 23 or 25 multi-stage cannula placed through either common femoral vein, and if this is under TE guidance. If drainage is inadequate, this can be augmented with a right atrial appendage cannula as well. When it comes to sewing ring placement and device insertion, the question is a regular mini cuff for sternal-sparing. I use the mini cuff in most cases. There are some exceptional cases where I would actually use the standard cuff. Certainly for device replacement, I always do it. I did a case yesterday where I actually used the standard cuff, and that was mainly related. Really, I thought mainly related to the suture placement as well, because I used all intracardiac pledgeted sutures because the tissue was very, very friable. Whether you sew and core versus core first is a surgeon preference. I personally have moved to coring first. When it comes to the suture technique, probably the most common approach I use is the four core, pledgeted sutures at 90-degree angles from each other, followed by a running proline. That's the most common approach for me, but you can certainly use all pledgeted sutures, external pledgeted sutures. I was surprised to find out in the most recent user meeting by Abbott, or now, by Abbott, that a lot of people actually use intrapericardial pledgets. But you can use running proline alone, but that tends to be, I think the minority of centers that do that. And this is just a little quick illustration on the technique of the running, the fixation sutures plus the followed by the running proline. You see your pledgeted sutures here, and we're running the proline around the sewing ring to finally fully fix the device. As I already mentioned, one of the challenging is actually inserting and locking the device. This is often one of the more difficult aspects of the case. With a HeartMate 3, really the outflow graft connector, the fixed bent in for the outflow graft attachment is probably the most challenging aspect of getting this through a small incision. You can always make your incision bigger, but it kind of, I think one of the reasons I do this is because I don't really want to make the incision bigger, and we never had this problem you really didn't have this problem with an HVAD. tips and tricks, I think because you're using the mini cuff, you can bunch your tissue. So you want to make sure that the pledgehead sutures are not more than a centimeter away from the sewing ring. It's not a big problem if you use the regular cuff, but it does become a problem with the mini cuff. You do want to keep the knots from interfering with the device. Not a big problem if you use the regular cuff, but that's become a problem with the mini cuff. Partially engaging the device, and then as a unit, returning the apex and the partially engaged device into pericardially before you attempt to lock it in place is one way to manage this issue. Occasionally, you can place your Alexis intrapericardially, and that's very nice because it does pull the apex almost right into the surgical field, and you can connect in that manner and return the device into the pericardium. We'll caution you that traction sutures are often more a hindrance than being helpful, just because you usually they usually make too acute an angle to actually let you lock the device. It's the outflow graft connection and bend relief. I think a connection is standard fashion. If you still have the old bend relief, I would recommend that you fenestrate this. And I use an aortic punch or CABG aortic punch to go ahead and do this. The outflow graft and the bend relief are connected. I tunnel them intrapericardially and occlude the outflow graft once it's access to the thoracotomy incision or the hemisternotomy. I briefly turn on the device to really get a good feel for the outflow graft length. It's probably not as necessary for HeartMate 3 as it doesn't expand as much as the old HVAD grafts did, but I'm somewhat paranoid about that, about having the graft too short. I'd rather have it too long, and that can be managed in multiple ways, but then having it too short, and that foreshortened graft actually can rotate the pump proper in a position that you really don't want it. You have a little bit less control of where the graft goes, but in general, I try to keep a loop along the inferior aspect of the pericardium, and then tunnel it towards the thoracotomy or the hemisternotomy. The partial occluding clamp is then placed on ACE and aorta, and the outflow graft anastomosis is constructed as before. And then the aortic graft, and ultimately end up placing and then release a partial occluding clamp. This is just a quick video about how the outflow graft anastomosis is sewn. This is actually sewn from the left side of the table. Normally a trainee does this for us, but for some reason in this case, I probably ended up doing this. But it can be done from either side. And the exposure is better than you think. Additional procedures, some of these can be done with a sternal-sparing approach. It really comes up, it's dependent on your level of expertise. And as full disclosure, I'm really not otherwise a minimally invasive surgeon. I don't consider sternal-sparing implants minimally invasive. Hemisternotomy or thoracotomy, they still hurt. They're big, there may not be big incisions, but it's, thoracotomies are not minimal incisions in my mind. The PFO is to close. Even for standard sternotomy cases, I don't usually close these unless they're large. Coronary disease, not treated. Valvular heart disease, I think based on your level of expertise, this can be performed with a sternal-sparing approach. I would do these by hemisternotomy. I'm just more comfortable doing that. But if you're adept at doing anterior thoracotomy aortic valve replacements or addressing the aortic valve, that's certainly a very good, that's certainly an acceptable approach. Some mitral valve repairs can be done in the setting of mitral stenosis through the apex. I've personally had to remove a stenotic band on one of the implants that I did, and it ended up working out okay. Tricuspid regurgitation, I now almost never address, and it has not seemed to be a problem. If I do plan on truly dealing with the tricuspid valve, I would more than likely do a sternotomy. Off pump, I'm not an off pump implanter. I think wherever it comes to sternotomy or non-sternotomy approaches, this tends to be practiced more in Europe. I think Igor Gorsev here in the US does a lot of these. I think, you do have to construct your outflow graft, anastomosis, and beforehand and tunnel it basically from your aortic exposure. This also can be used with a bypass approach to reduce cardiopulmonary bypass time, but it's not my standard practice. For apical management, you have to sew Dencor, and you do have to minimize introduction of air. I think the incision has to be bigger because your connection with the LVA left ventricular apex has to be perfect the first time, and it has to be error of 3. Now, other considerations, doing sternal-sparing implants in patients with prior cardiac surgery. This is actually a very good approach. I think it's not what I would start out doing when I first try sternal-sparing implants, but over time, I think you'll find this is actually it's an easier, less challenging approach, and with reduced bleeding. You do have to identify your cannulation strategy beforehand. Aortic and peripheral cannulation is often required to do these cases, particularly if you have to work around prior right-sided bypass grafts. One tip is the apex. You can't just expose the apex and implant the device. You could, but I will say especially the HeartMate 3 has a relatively high profile, and I think your patients will definitely feel it. And to really, also from the insertion issue I discussed earlier, in order to really get the device into the chest, you have to be able to place it at least somewhat intrapericardially, and you do need to mobilize the left ventricular apex. It's not as scarred the apex usually is not as scarred as you think, and this is not usually that difficult. Gaining aortic access, I just basically mobilize enough of the right ventricle off the posterior table of the sternum just to be able to pass the graft to either into the aortic exposure, to the thoracotomy incision or through the hemisternotomy. I almost perform a pericardial reconstruction. That's standard practice for us for all our cases. You can use bovine pericardium. I've moved to a CardioMed patch because I do think is more flexible. It's actually nice and thick, and it allows for tissue ingrowth. And my experience with one after transplant, I couldn't tell the difference between it and native pericardium. Changing gears just to kind of finish up, LVAD exchange. Actually, sternal-sparing non-sternotomy approaches are well suited for LVAD exchange, particularly limited pump exchanges only. What cases are suitable for this approach? Usually you can use a non-sternotomy, and that's usually just a left thoracotomy or thoracoabdominal incision for a primary pump or driveline defect, or limited extracardiac driveline infection, pump-only thrombus, and isolated device transfers. Full system exchange, extensive device is usually used for extensive infections. I do it pretty much for any case where I suspect there's pericardial infection. Also, if there is a outflow graft or abnormal issue or graft thrombus, or usually what's more common, extrinsic outflow graft compression that's not accessible through the thoracotomy approach. Need for additional procedures, is really dictated by your level of experience. Girardi and Al in this manuscript kind of outlined this. I think their approach to this is extensive. They perform sternotomies, recommend sternotomies for extensive infection, thrombosis, need for additional procedures, or upgrade to an incompatible device. But I will say both the HeartMate 2 and HVAD device transfers can be accomplished by non-sternotomy approaches. You can use a non-sternotomy approach for limited outflow graft issue, or for pathology involving just a pump or driveline or the more proximal aspect of the outflow graft. Pre-operative planning is important, even more so than for our standard cases. You'd hate to take somebody to the operating room and do a pump exchange only through a left thoracotomy and miss this. I think so. Standard practice for us is to do a CTA to fully image the device and the entire length of the outflow graft. You also need to identify need for concomitant procedures, and as already mentioned, vascular access needs to be identified, or certainly your options need to be identified. I'm not going to talk a whole lot about HeartMate 3 to HeartMate 3 exchanges. If this is a pump only, you can simply exchange the pump. You can do a graft-to-graft anastomosis, or you can just exchange the outflow graft. I'm going to talk a little bit about device transfers. I think for HeartMate 2, without an outflow graft issue, HeartMate 2 to HeartMate 3 device transfer, I generally use a thoracoabdominal incision where I use the interspace that gives me the optimal apical exposure, and come across the costal margin and curve it towards the xiphoid process to gain access to the HeartMate 3 HeartMate 2 outflow graft and vent relief. My general preference in really the device transfers is actually to fully replace the sewing ring and use intracardiac bledged sutures to bring them through the standard cuff. I think that's the most hemostatic approach. Also, often when you manage the apex, there's scar tissue, and the profile of the HeartMate and the profile of the HeartMate 3 and the insertion point is going to be different than what your old HVAD or HeartMate 2 was, and just redoing the apex gives you the most flexibility. But other options are described. This is a technique where you actually, the silastic of the figure here demonstrates that using the silastic inflow sleeve for the HeartMate 2 for connecting the HeartMate 3 device. Another option is to, what I've done this before, but it does cause, I think, more bleeding, is to cut it flush with the apex and then place external pledges and bring it through the sewing ring of the HeartMate 3 device. HVAD, this again can be performed for left thoracotomy only. You can remove the entire HVAD graft if you're inclined to do so, and some people recommend that, but we've done multiple cases where we've done the outflow graft to outflow graft connection through a left thoracotomy. Again, I prefer the sewing ring. Redoing the entire sewing ring. There are a couple of approaches to managing, alternative approaches to managing the apex. This approach here uses the HeartMate 3 HeartMate HVAD C-clamp, but uses a certainly unapproved felt glove tip as a gasket to provide a seal, because the external diameter of the HVAD is actually slightly larger, and you invariably would have bleeding if you just insert the HeartMate 3 directly. You can also remove the C-ring for the HVAD and sew the HeartMate 3 sewing ring to the sewing ring of the HVAD. But as I mentioned, I really prefer not doing that. I really prefer just replacing the entire apex. The graft anastomosis can be downsized, and it works. In my mind, it works surprisingly well. I think one thing you do need to do, for these patients, the device speed is higher than you would typically expect for a particular patient, but it's very manageable. One thing about infection, I think whether or not you do a limited or full system exchange for infection is sometimes a challenge. I think isolated driveline infections, at what point do you decide that this device needs to be exchanged? I usually give patients a debridement, but when I'm concerned that the infection extends beyond the intramuscular tunnel or is approaching the pericardium, I think really that those patients need to undergo a device exchange. It's very important to identify whether or not these patients have an intrapericardial component. We would routinely do TAG WBC scans or CT PETs, and now currently CT PETs is actually my preferred option, but you can't always get that as an inpatient to define the extent of the driveline infection. And, this is a patient that on the CT scan that had what was felt to be a localized complicated driveline infection, but a TAG white cell scan was a WBC scan is positive for involvement of the outflow graft and the bent relief. These studies are also useful for investigating occult bacteremia when you're concerned about device infection, and sometimes lead you to identify another source of infection when you suspect that it was the device itself.
Maybe another minute, Dr. Peltz, so that we have 10 minutes.
Absolutely, thank you. It actually will be 30 more seconds. Yeah, I think full system exchange for infection. One of the concerns about infection. Infection is a very morbid condition, as Dr. John illustrated on his slides. Even under the best of circumstances, and this Kaplan-Meier curve is from Dr. Pagani's group, who demonstrated a movement addressing these earlier, and potentially if tissue coverage reduces your reinfection risk to about, if you consider the 12-month infection-free interval reflective of a replacement, reduces that to about 25% from the numbers that were double that based on historical data. I think the key to this approach, device exchange for infection, is removal of all infected material. Soft tissue coverage with omentum, I think, is a very good option and a very good technique to reduce recurrence. And the CT scan demonstrates a case that we did where the device was fully replaced, and this fat density is actually the omentum in case covering the device and the outflow graft. I think I'll stop here, and I'll take any questions.
Well, thank you, Dr. Peltz, and thank you, Dr. John, for excellent talks. And as I said, I worked with Dr. Peltz, and he's very, very, very clear with the details. And just a point at Ranjit. Ranjit was 4 years senior to me in college too, so he was an astute student then, and he's an astute surgeon at the moment now. So it's good to be there for both of you today. We've got about 8 minutes, and I'll let Dr. Punan take a minute or two to explain the Indian scenario at the moment with VAD. But there's one question. I'll just ask quickly that question to Dr. Peltz on the chat is, how often do you convert from a non-sternal to a sternal approach? And that's a question to you, Dr. Peltz.
Yeah, I actually see a couple questions, and I think I'll address this all together. I think we convert. I've converted 2 cases since 2018. Both of them were related to one were related to exposure issues. And additional unexpected intraoperative findings that warranted a change in the approach. The more common scenario, if I convert, is I convert from a right anterior thoracotomy to a hemisternotomy. If I feel aortic exposure is not what it should be, I ran into a situation where we did a device exchange in a patient with an impella, and we withdrew the impella, and we had a lot of aortic insufficiency. That was unexpected, and I thought that was better addressed through a hemisternotomy approach. So it's really more, for me, it's more conversion to the hemisternotomy. Conversion to full sternotomy is uncommon. How did I get started? I think I had one of my partners at the time was a minimally invasive valve surgeon, and we had discussions about this, and he said that certainly, I think you can do these implants in this manner, and and I can proctor you some of the approaches. So I ended up going to Medtronic training lab to learn learn this on cadavers where you went through doing both approaches, and then with the assistance of and the mentoring of my minimally invasive valve surgeons, I started doing the first cases. And I would say the transition to going to almost all sternal-sparing was probably a 1-year process. I think the learning curve is to be fully comfortable is probably 10 to 15 cases. And I think you want to be selective when you first choose your cases. I think these are dilated ventricles, easy aortic access based on imaging. Those are the cases you want to do.
Well, thanks, Dr. Peltz. Dr. John, there are 2 questions. Any particular contraindications for VAD interventions? 1 minute for an answer and 1 minute for an answer for the other question too. In regions like India and low-income countries, do you think improved durability and hemocompatibility of HeartMate 3 may warrant a more liberal bridge to transplant strategy, or should these devices be positioned primarily as destination therapy only in selected patients? So, Dr. John, 1 minute for you.
I think each individual case has to be looked for its entirety of what's best for the patient. I do think, as in the United States, transplant is often the first option for these patients. But I think we all have to move away from the mindset that there are patients who cannot get a transplant, that by waiting and waiting and waiting, you don't want that candidate to become a worse candidate for other options such as LVAD. So whatever you think of, do it soon and do it quickly. These patients have days, weeks, months to live, and getting to them in better hemodynamic profiles is better for long-term survival.
Okay. Well, thank you, Dr. Poonen. Do you want to just talk about the Indian scenario? We both were talking today before the start of the session and said, well, on the record, there are 135 implants from India on the Abbott website. So, but you can tell me the reality of what's the situation in India right now, Dr. Poonen.
Ranjit, you had mentioned that after the 2018 change of the allocation, most of the bridge to transplants are done by temporary mechanical circulatory support, either VAD, as in CentriMag VAD, or by ECMO. I think we got there a little earlier than you because the durable VADs are so expensive. Generally, they're used as DT. We don't really use it as a short-term bridge to transplant at all. And transplant, according to our allocation criteria, at least in our state, if you're on ECMO or a VAD, as in a temporary LVAD or a BiVAD, they go up in their priority, and they get allocated an organ reasonably quick. So that is what we go to for temporary assist. And there are some more questions there's one from Dr. Murali asking, when do you declare death in a patient on total artificial heart? Either one of you can answer.
I think when these patients have cardiac arrest, we do CPR. Again, if it's in the early post-op period, you treat them like a routine cardiotomy, open the chest, tamponade, etc. And if they don't get back, their vital signs.
I think we need like end of life.
Yeah.
A patient is dying, and then you have these ventricular assist devices or total artificial heart working. So circulation doesn't stop.
Yeah, that's pretty standard. I mean, we look at other criteria. If they've had a massive stroke, for example, the pump's going to keep going. And as per the family and patient wishes, if things are futile, we turn the pump off.
Yeah, I would second that. I think if you reach the point of futility, that I think the pump, we just disconnect the pump at that point. I mean, we turn the pump off at that point.
Dr. Poonen, I think you bring about a good point. In the Indian scenario, what is the ideal patient to get a VAD, considering the costs, etc. Just like you have mentioned, we've also in here moved towards a transplant first option pretty much for a long time. The bridge to getting there has changed in the last 6, 7 years with temporary MCS, like as you alluded to, have been doing probably a decade prior to the trend here. But the question is, who would be a VAD candidate either in India or in the United States, especially with this transplant first option? I think that's kind of the key focus over the next decade in all around the world.
I think for us, the answer is reasonably clear because we cannot transplant a foreign national very easily. So VAD becomes the first option for them. The time on the waiting list for a foreign national could be years. So we generally recommend only a VAD, and if they get a transplant, it would be lucky. Lung still some people get, but heart, it's impossible to get a reasonably good organ for a foreign national. Then there are some patients who come in saying that they don't want a transplant, they only want a VAD. My friend has got a Mercedes in his chest, which is HeartMate 2. I want a Rolls Royce, so that I have a HeartMate 3 in my chest. So there are some patients who prefer that. For them, you can do that. But then the difference in cost between a transplant and an LVAD is so very much that it is not very justifiable using a durable VAD when you think that the waiting for a transplant is not so much. And even if we have to bridge somebody with a BiVAD, we are not bound by the FDA regulation, so we can keep a patient on BiVAD for several months. And then as and when we get a heart, we can do the transplant.
What about the patient with truly high PVR, which is occasional, and does that patient fall out of transplant candidacy? I'm talking about PVRs in the high fours that you're worried about in the post-transplant setting.
What we have been doing in the recent past is to put them on a balloon and see the response of, like you use VAD, we use a balloon, and see how they respond to, respond by reducing the PVR with a long-term use of a balloon. So we've been using a lot of axillary balloons for this purpose. And then check the PVR again on a balloon with a continuous cardiac output monitor. And if a reversibility has been established, and then we remove the balloon, and regardless of the PVR at the time of transplant or the peer pressure at the time of transplant, we go ahead and do the transplant.
Well, I mean, we've got 3 minutes, and I want to leave 1 minute to Dr. Rao if she wants to say a few comments, and then the last 2 minutes to Dr. Durai Raj to finish up. But I just want to show this picture. I just remember, who is the VAD person I know, and this is Dr. Silas Charles. He's from Andhra, but worked as radiation oncologist for 40 years in the U.S. in Florida. And about 6 years ago, he had a massive MI and he was offered a transplant, but he chose VAD. And this is 6 years and going, and he has gone back to Florida from San Francisco and sitting in his old office. But I asked him one question: what is it that makes you have a VAD for a long time? And he told me that a person with VAD should have a will to live. And I think it's a good thing. It's often many of them go into depression, a lot of mental health, this thing. And he said that he doesn't have, he has will to live, and that's what keeps him ticking. I'll stop there with that image, and I'll pass on the time to Dr. Rao for a minute, and then Manoj can wind up this thing. But just figures there. Remember, 1% of India has heart failure in some form or the other. That's 15 million people. At least 1 million people are end-stage heart failure, and they need 200,000 heart transplants in a year in India. So there is a lot of work to do. Maybe indigenization. I read about IIT Kanpur doing some indigenous devices, and whatever it needs to be indigenized. 2001, when ECMO started in AIMS, people were making fun. Hey, ECMO, it will never be useful in India. It's so expensive. That is 2001 in AIMS. And now look at what ECMO is. It's every day, everywhere, in every hospital in India, so popular. So I'm sure in 10 years or 15 years, VADs will be there everywhere. So just hold on there. I'll pass on to Dr. Rao and then Dr. Manoj Zorairaj to finish up.
So Dr. Rao just left to the OR,
Dr.
so I think
Bhatti,
so Dr. Manoj sir could go on with the conclusion of this webinar. Thank you, sir.
Yeah. Thanks, everyone. And on behalf of Dr. Jabir, President of the Society of Heart Failure, and also myself as a secretary, I'd like to thank everyone, especially Dr. Ranjit John and Dr. Matthias Pels, Dr. John Murala, and Dr. Julius Punan. I'd like to thank especially Chris, Madhuri Rao, and Dinesh for spearheading the STS project. And we are proud partners in this field at the moment. And we are looking forward to having maybe the STS coming in to India during our annual meeting, which will be held shortly. We'll announce that soon. So we'll be looking to having a partnership with the STS also. At the back end, I'd like to thank Karen as well as Amanda and Scott, who have been always playing a pivotal role in all our STS meetings. Thanks to you, guys, and thanks to everyone who have joined us. It's so nice that you could spare your time on a Saturday evening. And looking forward to next webinar with the STS through the webinar series. Thank you, everyone, for joining us.
Thank you so much to our moderators and our panelists for your participation and insight. And thank you all to all our attendees for joining. We hope you found this webinar valuable. If you're not one already, we invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership or scan the QR code on your screen. Also, registration is now open for STS 2026 in New Orleans. Find more information on the calendar of events at sts.org or scan the QR code on your screen. We hope to see you there. Lastly, we have some great information from IACTS Con taking place February 26th through March 1st in Mumbai. Hope to see you there as well. Lastly, we are very excited to have our next collaboration webinar with many organizations, including ESTS and WGTS, on the surgical management of infectious lung diseases, 8 a.m. Eastern on Saturday, January 10th. So until then, please have a wonderful holiday season and a happy and a healthy new year. Thank you so much and have a great day. Thank you, everybody.
Thank you.
Thank you.
Thank you.